I am Youngjae Kim, the director of the Korea Dental Hospital. This patient is someone I have known for a long time. This implant was placed a long time ago. It was placed approximately 25 years ago. This one is an implant from about 10 years ago. And finally, this one has been in place for about 5 years. It's known as platform switching. It refers to the phenomenon where there is space between the implant and the abutment, allowing the bone to fill in, which has a very good prognosis. The patient felt tenderness while chewing, so I thought it might be better to extract the tooth and proceed with the implant, and decided to place an millimeter diet implant. There is sufficient bone volume, and it seems to be a typical case, so the surgery should not be too difficult.
사분을 컴퓨터입니다. 4.5mm 컴퓨터입니다. 핸들로 연결해서 확인하면서 가볍게 컨트롤해서 보는 드릴입니다. 핸들 힘으로 같이 커브 들어가고요. 실링 클럽 그리고 이상 컨트롤 약간 매저를 붙였네요. 자르겠습니다. 더블로 쪽으로 맞춰 자르시면은 2차 아주 편합니다. 추천은 팔자 피겨에
An millimeter idiot implant. The depth at which the fixture is placed is important, and there is a concept called emergency height on the abutment. In the past, the connection part of the implant abutment couldn't have its length adjusted, so it was always placed flat on the crestal ridge. However, recently the concept of EH has emerged in implants, and there are both long and short versions of this. It is now possible to match the abutment according to the level at which the fixture is placed, so recently fixtures are being placed a little deeper. This is an implant I placed about 25 years ago, and you can see bone resorption up to the first thread. The same goes here. When not placed deeply, the bone is maintained up to the top of the implant. This implant is also about 25 years old, and you can see the phenomenon of bone resorption up to the first thread. Thus, it is an established principle in dentistry. Bone resorbs up to the first thread. However, if the fixture is placed deeply, an EH concept abutment is used, and an implant abutment connection that locks or creates a conical seal is used. The surrounding bone does not resorb and may even regenerate. Therefore, the recent trend is to place the fixture slightly deeper and use an abutment with a strong connection and a conical seal. There is no micro-movement, and a perfect conical seal is achieved, preventing bacteria and other oral flora from penetrating inside. Therefore, it is developing into an implant that does not smell. SLOCK implant, Torx++. Torx++ connection also achieves a complete conical seal, and the abutment connection is strong, so the fixture was placed about 3 mm deep. Since the bone is not flat, 3 mm is not an absolute value. In reality, it is less than about 2 mm on the buccal side, and less than about 3 mm on the lingual side. The direction is also good. There is not expected to be any particular problem. Therefore, if an abutment with a prosthetically appropriate EH is well selected, EH will be achieved without much difficulty. Then the abutment is like this. Now, if you just properly place the crown here, good results can be expected. Looking at it on the CT, it is slightly unsatisfactory. The fixture apex slightly impinged on the buccal cortical bone. On the contrary, when cortical bone fixation occurs and the initial fixation significantly improves, eventually cortical anchorage increases. In cancellous bone, the initial fixation force, known as ISQ, cannot form beyond a certain limit. Therefore, it is important to obtain cortical anchorage somewhere. And since it is an millimeter idiot implant after extraction, I think it is crucial to obtain cortical bone fixation from the lamina dura of the extraction socket or from the buccal or palatal side. The placement position of the fixture is also good. I don't anticipate any particular problems. If you look at the implant of the first molar on the posterior side, platform switching is applied. The bone has filled up to the abutment contrast level. The prognosis is excellent. There is no cortical bone anchorage, and it is implanted in cancellous bone. In such cases, the initial fixation might have been slightly reduced at the time of fixture placement, right? Therefore, I advise that after sufficient time has passed and bone regeneration has occurred, the second surgery can be performed. And it's the same. There are cases where the abutment is hurriedly connected, but from a surgical protocol standpoint, abutment connection is optional. In my case, if the success rate drops even by 1%, I do not proceed. I believe it is correct to perform a second surgery and connect the abutment accurately. We used a healing plug during the surgery. In most difficult cases, many use a cover screw. When you connect a cover screw like this, the bone fills up completely. Then the second surgery becomes very difficult. I think many avoid connecting the healing abutment in millimeter diately due to this difficulty. The SLOCK implant system allows you to cut the healing plug as desired. Because it is inserted by cutting, during the second surgery, you only need to remove the healing plug, not the screw form. Clinically, it also offers convenience, and as it is inserted, it creates a conical seal. Complications like secondary infection are also minimized. Clinically, due to the convenience and minimization of infection, the use of the healing plug is recamillimeter ended. By using the healing plug, we can verify the direction in which the implant is placed, facilitate the secondary surgery, and it has the advantage of minimizing infection during the healing period after the implant is placed. So we strongly recamillimeter in the use of the healing plug. The direction is good, the position is good, and the depth is good. Therefore, I believe this implant will last a very long time. That's all. Thank you.